one that a lot of us are talking about, discussing, reading about, thinking about, some on a very personal level, some on a very professional level. Some of us are thinking about it in terms of ethics as well. That is the issue of duties to care, particularly in a pandemic like the one that we're in now. And I'll start with a question, which is, should I stay home today? Takeaways from our time together will be these: healthcare workers, both professional and others that may not consider themselves professional, healthcare workers have duties to care, which are grounded in various ways: principles, virtues, oaths, standards, etc. Healthcare workers' duties to care are not without limits, are they? Duties to care foster moral dilemmas. Yes, they do. We'll look at some case situations. A COVID-19 pandemic fosters unique moral dilemmas in regard to duties to care. Those healthcare worker duties to care moral dilemmas are not without potential resolution, and there are resources that exist to help. And finally, I'd like for us to end on this note: unresolved duties to care moral dilemmas foster healthcare workers' moral distress and potential harms. So we want to work on resolution. And one way that we do so is by getting together like this and thinking together, talking together. That's what we'll do. So this is today, this morning. Some of you have been reading news items. Some of you may be nurses who are involved in something like this at a Las Vegas hospital, or this RNs at 15 HCA hospitals protest lack of COVID-19 preparedness, PPE, etc. So I could probably just leave this slide up and not say anything else, not show any other slides. And we, especially if we were all in a physical space together, could have a very good discussion, probably impassioned discussion, just on the basis of this slide and this happening that's going on as of today. But let's go back a little bit. I'm not going to go back as far in a historical perspective as my colleague Carla Kearns did last week. I'm not the historian that she is by any means, but I can go back at least a few years, a decade, and some of us remember H1n1. So back in 2009, this was a story that showed up. Mission, Kansas, 1,800 Johnson County residents begin Halloween by taking steps to prevent something scary, the H1n1 virus. And so this photo, if you can't see it well, shows a long line of folk who are lining up at the Johnson County Health Department clinic to get a vaccination against H1n1. That was just over a decade ago. A decade later, here we are. The Johns Hopkins coronavirus website, which is frequented by millions, maybe billions of people multiple times per day, that shows how many confirmed infections, how many deaths, how many recoveries by country. And then we're following that on a national level and on local levels on our state health department websites as well. Just a few days ago, Governor Kelly in Kansas issues a statewide stay-at-home order. So, given that, should I stay home today? Yes. Maybe? No? Well, clearly it depends. Here's a case that I parenthetically say is not a real dilemma, but let's look at it. Let's say that Chris RN wakes up Monday morning with symptoms not unlike some said to be indicative of COVID-19, fever, cough, congestion, achy muscles, headache. Typically, Chris would welcome a sick day and maybe even quarantine at home, but it's the end of the quarter. All PTO days have been used up. This one would be without pay, unless there's some provision for pay, stay-at-home pay. But maybe there's not. Anyway, the team really needs Chris to show up. And if this would happen to be COVID, well, I'll bring my own masks, and everyone in the hospital probably has been exposed already. So what the heck? What ought Chris RN do? Now here's more of a dilemma. We'll come back to number one. But let's say Chris RN stayed home from work last week, got tested for C19. He or she is negative. Chris has been symptom-free long enough to return. Now the nurse comes to the hospital and finds that PPE is scarce. Conservation requires nursing staff supply their own masks, otherwise no N95 use except for C19 positive patients, then reuse it until it falls apart or the supply increases. And I'm actually quoting, these are the conservation requirements of a close relative of mine who is a physician. And this is actually what she messaged to the family about a week ago, that this is what she is encountering in her hospital as a hospitalist. Reuse the N95 until it falls apart. Surgical cloth masks are homemade, community donations. The aunties sent those to this family member for her use. Paper gowns are reserved for care involving bodily fluids. Eye protection is so scarce that nurses wipe and share. Again, this is real. I don't know if it's real in your facility. It was real in my relatives, my family members' facility. And to my knowledge, it's real today. Chris's patients are all suspected C19 awaiting test results. So not C positive. What ought Chris do now? And what are a healthcare worker's duties to care under conditions of PPE scarcity? Here's another case, maybe even a bigger dilemma, although that one's significant and big. Chris RN wakes up one morning 2 weeks later, but wonders what to do now because the hospital is on crisis standards of care. This could be the case in the Kansas City area within, we're told, about 3 to 4 to 5 weeks. There have been many deaths at that point, let's say, including some healthcare workers. Chris really can't afford to get sick, much less die. There are dependents here at home. My kids need me. Family elders require care. Mom needs me. 2 team colleagues already have succumbed. And although they're recovering, they tell Chris what it's like. Not nice, not fun. Chris still has PTO days saved for such a time as this. What ought the nurse do today? And what are one's duties to care given competing duties? Come back to that. So, duties to care dilemmas. What Chris faces as moral dilemma is shared by many healthcare workers in a crisis such as this one. Nurses, yes. Physicians, certainly. Technicians of various sorts, respiratory, occupational therapists, speech language, dietitians, social workers, CNAs, COs, also constant observers, and those who work behind the desk, those who are managers, custodians, chaplains, maybe even clinical ethics consultants. When my pager goes off, as it has multiple times this past month, as an ethics clinical ethics consultant, ought I go in or ought I stay home? Each healthcare worker, regardless of role, has duties. Each one has others who are counting on them to show up for work, even if that show up is in a virtual format like we're doing today. So back again, now this time back to 2006, more than a decade ago, we were thinking about the potential of a pandemic, and I remember hearing on NPR, Talk to the Nation, an emergency department physician calling in, who in anticipation of pandemic said, our #1 concern in emergency medicine is, are people going to come to work? So ethics case #4, which is an actual dilemma that was posed to me a bit ago. Suspected C19 patient arrives by EMS. One emergency healthcare worker says to another, I'm not doing this one. Sorry, I got kids at home. If this were to happen, or when it happens, what should happen next? And what are one's duties given competing duties? Is this situation merely a lack of courage and collegiality, or is something else going on? We need to think about that as well and not rush to judgment. So back in 2006, a writer said this challenge was apparent both in the HIV/AIDS epidemics of the 1980s and in the 2003 SARS outbreaks in Toronto, in which some doctors and nurses did refuse to treat afflicted patients on the grounds that they presented too great a danger to do so. And then in regard to Ebola in parts of Africa, when a physician visited the 1995 Ebola virus outbreak in the Democratic Republic of Congo, he found 30 dying patients in an abandoned hospital left to care for themselves amid rotting corpses, sometimes in the same bed. So the question is raised, was the last doctor justified in leaving those patients? Or should he or she have been obliged to single-handedly treat the highly and dangerously infectious Ebola patients? The question of duties to care amidst pandemic situations is not simple. It's not easy. And so we need to think about it. We're going to think about it in terms of 3 questions, looking at norms and limits to duties to care. So first question, what are healthcare workers' duties to care? What are those duties? What normatively grounds them? And what are the limits to one's duties to care? So first of all, what are healthcare workers' duties to care? Here's my definition. Duties to care are obligations arising out of one's role and abilities, specifically to show up, to fulfill one's role, to act responsibly. We'll talk a little bit more about that. To act beneficently and not harm persons, to be a team player, collegial, to follow standards of care, sometimes crisis standards of care. And what am I missing? Ryan, Matthew, is there anything else you would add to this short list? Others of you might add something to the chat. But this is a good start. Show up, fulfill one's role, act responsibly, beneficently, don't harm, be a team player, follow standards of care. What normatively grounds duties to care? Let's start with Kant. So Immanuel Kant is someone whose theory is deontological, it's a rules-based method versus teleological or ends-based methodology. You ask the question, what ought I to do? Deontologically, what I ought to do is to do my duty, according to Kant, obey the rules. If I am more teleological in my orientation, what I ought to do is what will achieve the ends that I seek. Kantian duty ethics, duty is from Kant's perspective, duty is that action to which one is morally obligated. One is morally obligated or duty bound to obey rules, worthy rules, hopefully, and consequences matter less than having obeyed the rules. For Kant, a fundamental rule, for all of us, really, a fundamental rule, or what is you call the categorical imperative, is to ask, to take on only those rules that you could will to be universal. So you ask, what if everybody did it? And that's a question we've asked ourselves since our parents first asked it when we wanted to do something that they thought was probably not wise. What if everyone did it? So that's one place to start. On Kantian duty ethics, then what ought Chris RN to do about going to work with a fever, about not going to work because of competing duties, about not going to work on account of insufficient PPE protection. What should the reluctant healthcare worker do when the COVID patient shows up in the emergency department? Well, one way to resolve those dilemmas is to ask, what if everybody did it? What if everybody went to work with symptoms, didn't go to work because of their competing duties, didn't go to work because they didn't feel protected, didn't take the patient who comes in suspected of COVID? What if nobody did it? There are other relevant norms that ground duties to care, and here are a few others. The norm of responsibility, which is the ability to respond to a situation of need. Norm of beneficence, non-maleficence, justice, trust, a social contract. Non-abandonment of patients, reciprocity, such as the golden rule. Multiple agency, we'll talk a little bit about that. Not sure that's the correct terminology, but I couldn't think of another one that would cover that. That was better. Proportionality, professionalism, collegiality, virtues. So responsibility. I am responsible for that to which I am able to respond. And so in any particular situation of what ought to be done, one is asking, who is responsible? Am I responsible? If I'm able to respond, I might well be responsible, but then to whom and for what? Beneficence and non-maleficence ground duties to care. Surely we ought to do what is good for our patient or for our colleagues. We ought not to harm. Justice, we have duties to provide care that is fair and equitable. Trust grounds that grounds our duties to care. That social contract that healthcare workers and others have, but healthcare workers in regard to patients, and also the public trust. As we're thinking about and drafting guideline documents for triaging scarce resources, we're constantly thinking about how will this go down in terms of the public and their trust in us to do what is beneficent and just. Non-abandonment of patients. Back one, in terms of the social contract. Chris Krenner, who is not Chris RN, but Chris PhD and MD, wrote to me as he was looking at my topic for today, and he had to be on another webinar at the same hour, so he was sending me some of his thoughts. and these are some of them. Chris wrote, "It seems to me that the duty to care in healthcare has a deontological basis, yes, and is not qualitatively different from a broad and basic moral obligation. Some people talk about a social contract for healthcare, like me. But Chris says, I am suspicious of the historical stability of that claim. Doctors' relationship to society has changed pretty radically across time and culture. If there is a contract, it looks pretty loose-knit." Do you agree with that? Something to think about. And I'd like to have that conversation with my colleague at some point. You might too.
Yeah, I sort of wonder how long how long of a historical horizon you really need to say that there's a social contract. I mean, if there's like significant professional sovereignty for healthcare workers now, then it seems like you could say that there is a social contract for healthcare, regardless of the fact that if, 100 years ago it wasn't like that. But yeah, it's an interesting conversation.
From a historical basis, the role of the physician has dramatically changed since the early 20th century. Before that, physicians kind of operated outside of society as this pinnacle of goodness. And now when they started to be controlled by society in terms of regulations and governmental procedures, that's when the social contract of responsibilities really came about.
So additional thoughts. Thank you. We can come back to that as well. Another norm that grounds duties to care, of course, is non-abandonment of patients, which are written into all sorts of codes of ethics, oaths that physicians, nurses, others may take, including the American Osteopathic Association Code of Ethics, which starts off in Section 4. A physician is never justified in abandoning a patient. Now they have some caveats to that in their code, but that's a pretty strong statement and claim. Would that apply also to Chris RN, to social worker, to OT, RT, others? Then there's reciprocity. We all live our lives by this one in various formulations. This is the one that I grew up learning from the Bible. Do unto others as you would have them do unto you. If you live your life by that, if Chris RN does, what would Chris want other healthcare workers to do? Show up or stay at home if Chris themselves were their patient? That's one way to think about duties to care. Multiple agency. Again, I'm not sure that's the best term, but I'm referring to multiple duties, really, to patients, colleagues, to family members. Each one of us who has duties in a healthcare setting also has other duties. How do they weigh against one another in any particular situation? That matters. Proportionality. And here's where some nurses are protesting that the caregiver risks without sufficient PPE may outweigh benefits to patients, and patients are also placed at risk if nurses and other healthcare workers, like my family member physician, are not adequately protected.
And we have a question that's kind of in line with that. Comes from Kim, that says, do healthcare workers have an obligation to work with administration to ensure proper protective equipment is adequately available? Does administration have a duty to care for employees and ensure that proper protection is available, or expedited processes in place to obtain such?
Right, so there's multiple agents, moral agents in healthcare context as well. So we're talking about duties to care. I'm using the example of an RN or an emergency department healthcare worker, physician, let's say, but there's also administration, hospital administration. as my life partner and I, who is an RN, we're talking this morning, she showed me the article that I started out with, involving HCA nurses that were about to protest, and we discussed that a bit in terms of, so if there isn't PPE, what is the hospital administrators supposed to do if they can't access it? So yes, maybe there should have been foresight and better preparation. Perhaps some hospital administrators prepared better than others, but there's a catch-22 for hospital administrators right now as well, surely. Trying to access resources that are hard or impossible to get. So yes, there are duties, obligations that go beyond the healthcare workers, especially those on the front line. Professionalism. I'm thinking of healthcare workers in a benefactor role, which is a for you relationship. I use this visual oftentimes in my teaching, and I'm looking over on the left-hand side right now where there's an arrow, and looking at this part of the relationship, the benefactor-beneficiary relationship, where the healthcare worker is a benefactor in a relationship that goes really one way. It's a for you relationship from the benefactor's perspective. From the beneficiary, the patient's perspective, they are there to be cared for. It's a relationship for me. Are there some shared responsibilities? Yes, but we think in terms of vulnerability and power as well, and the person with the greatest vulnerability has the least responsibility in that relationship, whereas the person with the greater power of resources, status, degrees, knowledge, skills, tools, being vertical versus the horizontal patient. All of that is power relative to vulnerability, and therefore there is a duty to utilize that power in a way that is beneficial to one's patient. So that's part of what it means to be professional. Collegiality also, sharing the load, being a team player, and then many virtues. I've just listed a very few here: compassion, altruism, self-giving, courage. We could add many other virtues. But the notion of virtue is that picture we have in our mind of the good doctor, the good nurse, the good ethics consultant, the good healthcare worker. What would, if I am good, what characterizes me? Certainly compassion, certainly altruism, thinking of the other even more than myself, and being courageous, and other virtues. So let's go back to Chris RN. First, not a real dilemma, but let's look at it and see how some of the norms for the duties of healthcare apply, making it pretty much not a moral dilemma. So Chris wakes up with symptoms, but instead of staying home, ponders the possibility of going to work anyway. What ought Chris to do? I think we would all agree that Chris ought to stay home. Sort of a duh, of course, at least in this sort of situation. Why? Because of non-maleficence. Don't harm people, which one might do if going to work with symptoms, especially if it turns out to be something like COVID-19. What if everybody did it? That Kantian categorical imperative question, hospital policy and our duties to obey that, and surely hospital policy now says stay home if you're symptomatic. Maybe not, but maybe should. And golden rule, would you want, if you were the patient colleague? Would you want somebody else showing up with COVID-like symptoms? Probably not, so don't do it. So third question, we talked about what are the duties to care for healthcare workers, what grounds those duties to care, but then now let's go back to the question of limits. Are there any limits to one's duties to care? I'm guessing that we can all imagine some limits. Let's go back to case number 2. Chris RN stayed home from work, did the right thing when symptoms were shown, but got tested as negative, has been symptom-free long enough now to return, returns to the hospital and finds that PPE is scarce, like it is almost everywhere. Conservation policy now requires all those things that I had read earlier. Chris's patients are all suspected C19, awaiting test results. What should Chris do? What are a healthcare worker's duties to care under conditions of PPE scarcity? So Matthew's and Ryan's and my boss, John Carney, gave his opinion a little bit ago. Well, was it yesterday? Day before, writing to some colleagues elsewhere, and then shared his letter with us. And here is what John is thinking. And maybe Ryan, you could read this. I have 5 slides, so just to change voice here a little bit, use your best John Carney voice and read this next 5 slides, please.
Absolutely not. I will read it, but not in John's voice. A decade ago, our assumptions were a bit different. We had PPE in adequate numbers and confidence of deploying real stockpiles that were to be readied on a moment's notice and shipped to hotspots. We knew we had in short supply of vents, but actually we had a plan to move them along with the spread of the seasonal illness from one part of the country to another as the wave of disease spread. That was a different time. Oh, we also have prophylactic like Tamiflu that was targeted or reserved in adequate supplies to ensure the safety of leaders conducting triage and officials making public health declarations. We had plans for alternate sites of care. And now what do we have? A gutted and impoverished public health system, ill-equipped, unfunded, and unable to prepare, let alone respond. Public health and civic leaders reluctant or absent in some cases. And the consequences of that is that you are left to battle this disease with sacred oaths and ungloved hands and naked spirits and shields made of tendency and homemade masks and sacred oaths. If this society promised you protection and safety and you don't get it, then yes, you probably don't deserve to go to the front of the line when it comes your turn. But you don't have that. You didn't deliver on that promise and the deal is off. You deserve better from us. So do your colleagues serving beside you and in nursing homes?
And what John is talking about here is the debates that are going on about triage guidelines, some policies of which are going to say that if there's 2 patients who need a vent, there's only 1 vent available, the tiebreaker might be that you are a healthcare worker. John is weighing in on that and saying, yes, especially because we didn't deliver on the promise. And therefore, yeah, that's the least we can do.
And for those who treat and care for those on the streets and packed in high rises where social distancing is nothing more than a myth, we offer nothing more than platitudes and praise and maybe a prepackaged meal. Shame on us. So my thinking is maybe that social contract with you has been voided, not by you, but by us.
So, do you agree? Some of you likely do. Others of you might want to think about it a bit longer, and some of you maybe don't. We could talk about that. Ethics case number 3, Chris RN wakes up, wonders what to do today. Should he or she go to work? Hospitals on crisis standards of care. We don't have enough vents. Maybe you don't have enough dialysis machines. We don't have enough staff. We don't have enough the appropriate medications. Maybe we don't even have enough beds. There have been deaths. My kids need me. Mom needs me. Colleagues are getting sick. I do have PTO. What are one's duties to care given competing duties? And then that other one, that case number 4, where the emergency healthcare worker says, I'm not doing this one, sir, I've got kids at home. Is this merely lack of courage and collegiality, or is it something else?
And we have a question that articulates a scenario that's pretty similar to that one, that says, what about the moral distress of a parent who is being threatened with losing custody of children if they continue to work as a nurse? So like societal pressures that come in from the outside.
And there are probably no end to situations of particularity that make this incredibly complicated and complex. Not an easy stay at home or go to work sort of decision. So yeah, that would be another part of the equation that would weigh one's duties to care to patients over one's duties to be a parent and to not to the value of custody. So we can imagine some exceptions, I think all of us, to a healthcare worker's duties to care, particularly now for COVID-19 patients. This is a sort of white paper draft that I haven't done anything with yet, except to send to a few people in one of the hospitals when asked to help think about possible exceptions to the duties to care. And the exceptions that I listed is it is considered ethically permissible, perhaps, to remove healthcare workers from the front line, at least, on the following grounds: medical, that the person has immunocompromised status, maybe pregnancy, some other medical condition, a familial, who have family caregiver responsibilities, for which this could be very risky, competency, lack of expertise, and haven't received the necessary training, or vulnerability because of one's status, perhaps as a student or a trainee, or perhaps for lack of available PPE, which increases one's vulnerability and risk. Not everyone agrees with that list, I learned, as I did some more research. One hospital's work policy that was posted, sent to me, says that staff over the age of 60 who are pregnant, immunocompromised, underlying health conditions should continue to work per their regular schedule. If you have concerns about that, talk to your team leader or manager. We understand the concerns, management says. We're here to help navigate the conversation. But all, and they say we have PPE policies, protocols, recommendations for designed to protect. But the conclusion is you go to work. Virtually no exceptions to duties to care at that hospital. The VHA a few years ago, a decade ago, in their document called Meeting the Challenge of Pandemic Influenza, gives ethical guidance, and in this section about the ethical duty to provide care and non-abandonment, they acknowledge, they empathize with familial competing duties, but pretty much are not giving an exception to staying home. Just try to remove barriers to work attendance is their approach. I'm not sure if that's been updated. So not everybody agrees with exceptions that you and I might think about. And there's all kinds of policies out there right now, and all kinds of feelings and thoughts and actions in regard to that, in response to that. So takeaways, again, healthcare workers do have duties to care, which are grounded in various ways, not without limits. At least some of us believe that. Moral dilemmas do arise in the particularity of our situations. COVID-19 raises them in particular as well. They're not without resolution, at least in some cases, and there are resources that exist to help. This one is old, but it's still relevant. It's available on the Center for Practical Bioethics website. It was a publication that we did anticipating pandemic, like we finally got more than a decade later. But you can find this on our website. There are articles about preparedness, deciding what's fair, disparities, the importance of community input, and others. And there are many other resources being posted now on our website, which is practicalbioethics.org. Want to end with this one. Unresolved duties to care dilemmas foster healthcare worker moral distress and potential harms. And so working together, like we're doing right now, consultation, collaboration, dialogue sharing, I think by working together, we will enable a greater resolution, the greater possibilities of resolution, more so than any of us might do on our own. So that's my last slide. And I think we still have a few minutes for some dialogue. Either Matthew or Ryan, if you have some thoughts, or if there's some comments or questions that are being posted.
Well, we have one scenario that's been volunteered by Richard that says, your hospital has only 3 critical care physicians. He or she had inadequate PPE and high COVID exposure. The physician is seriously ill and requires a ventilator, which is currently subject to triage. Should that physician be given preferential treatment? If so, what about nurses, RTs in the same situation? So this is the kind of the framing, similar to what John was getting at in the quote that we read, but also highlights kind of the way that the material constraints are factoring in here.
Yeah, and so the answer is it depends who you ask. There are differences of opinion on whether healthcare workers, even those who are on the front line and get sick on the front line, if those should be prioritized in a tiebreaker dilemma for event or other resources.
So I can see kind of 2 ways to frame that. Like one is like you would prioritize them because they have made this particular sacrifice and are deserving of that, of kind of like some kind of compensation for that. And then another sort of way to frame it would be something like that there are certain strategic reasons to consider giving preferential treatment to your care workers because they play an important role, and restoring them to health is an important part in maintaining that role. Is there, can we speak to kind of the differences in how we might weigh those 2 approaches or those 2 framings?
Yeah, Ryan, do you have any thoughts on that?
It just seems you're making it like a utilitarianistic argument of doing the most amount of good. And if you have 2 people and one is a healthcare worker and one is not, if you treat the healthcare worker and save them, that person can then go on to treat others. So It's a down the line causation of how much good can you do by saving one, you can save even more. I think also too, when you're getting at a point where you have equals and you're making decisions, any variable that you can find to justify one over another, you're going to start pulling.
Yeah. So, so in one of the discussions I've had, there has been the thinking that we owe this to healthcare workers, and on a personal level, I have two nieces, at least one nephew, brother-in-law, a daughter-in-law, who are all healthcare workers in clinical settings who are potentially at risk. I could very easily, on a personal, familial level, will that their institutions would prioritize them if, God forbid, they end up needing a ventilator. On the other hand, one of the institutions where I'm involved in discussions of this very question, drafting the triage guidelines, there is not an inclination to write that in, but rather to use something more like a lottery, random allocation once we get to the need for a tiebreaker, so as to not, it's primarily based on public trust, so as not to violate the public trust. Now, John Carney would argue that the public is on this. The public is loving on, thanking, so grateful for healthcare workers, that this would not be a hard sell. And that's probably true at this point. But on the other hand, I don't think there's any hospital and any physician, a healthcare worker that wants to be seen as serving ourselves before the community, and prioritizing ourselves, because we're making up the rule. Hopefully with community input, but I don't know how much that's happening right now, given the urgency of getting these documents up and implemented. So, good question. And the answer is that there's a lot of debate out there, and hospital policies are going to vary pretty clearly on that question. Are any other comments or questions on the chat feed?
I'm not seeing any right at the moment. And I know that you mentioned having to make it to another meeting. Yep. So it might make sense that we conclude here. So I'm gonna go ahead and say we do that. Thanks to everyone who was able to tune in to the Ethics Committee Consortium webinar today. And thank you to Terry and for putting the presentation together. And thank you to Ryan for being on and being an interlocutor with us. So just a reminder, we record these and they'll be posted to our YouTube channel, which you can find by searching Practical Bioethics on YouTube. And keep an eye out for updates about upcoming webinars. We have another one Thursday of next week. So we hope we will see you on then as well. So thanks again, and we will see you next time. Bye now.
Thank you.